Good afternoon, everybody. For those of you who are tuning in now, my name is Will Mabey. I'm the Community Relations Coordinator for the Center for Indigenous Cancer Research. Our guest today is Melissa Jim. This is our second webinar in a series of yearly webinars we're doing through our center. Melissa graduated from the MPH program at the University of New Mexico School of Medicine in 2004. She has been an epidemiologist with the Cancer Surveillance Branch in the Division of Cancer Prevention and Control at the Centers for Disease Control and Prevention in Albuquerque, New Mexico for over 15 years. She conducts data linkages between all central cancer registries in the United States with the Indian Health Service IHS patient registration database, with results so significant that the linkage has become an annual central cancer registry requirement. She is a co-PI on a project involving the linkage of the National Death Index, which is maintained by the National Center for Health Statistics with the IHS patient registration database to improve the quality of race data for death records. She also provides technical assistance and analytic support for IHS and tribal organization. Prior to working for the CDC, she worked at the New Mexico Tumor Registry for 5 years. And Melissa, if you want to unmute and maybe add to that introduction. I know it was a short introduction, but we want to honor all the extra work that you've done in Indian country so far in the past 15 years. So if there's anything else you wanted to add in terms of your credentials, your personal life, feel free to add that now. Love to hear from you.
Not really. That covers everything work-wise. I do have a slide that'll cover like where I come from. So I don't know if you want me to start showing my screen now. Can you see?
Yep, looks good.
Okay. So this is our generic CDC slide, but just shows what I'll be talking about. My name is Melissa Jim, and I'm originally from Shiprock, New Mexico, which is on the Navajo Nation. I have a little map here that indicates where the Navajo Nation is located, and it's approximately about 27,000 square miles big, and it's larger than 10 of the 50 states in the US. So it's about the size of West Virginia, and that's the state I have the little X marked on. The population density is 6.3 persons per square mile versus 345 for the US. When I first showed that slide to some colleagues of mine at CDC, they were like really surprised, especially the developer of the linkage software that we used to use. He was from China, and he was like, 6.3 people per square mile. Like, he couldn't fathom that number in that vast amount of space for only 6 people. And the Navajo Nation racially is 95% Navajo or American Indian and 4% white. So that's a little background information. The next thing I wanted to talk about is why I'm located in Albuquerque. Originally, I was one of the assignees that were located in the Indian Health Service headquarters west when it used to be located in Albuquerque. And this kind of shows you the CDC assignees that are still in Albuquerque, even though headquarters west moved to Rockville, or there is no headquarters west anymore. Everybody that was in IHS headquarters are now in Rockville. And this little graph shows you the CDC folks that are still out here in Albuquerque. And they are in the purple boxes at the bottom of the screen. So at the Division of Cancer, which is where I'm located, there's 3 of us assignees. There's myself, and there's Stephanie Malconian, and Don Haverkamp from the Epidemiology and Applied Research branch. I'm from the Cancer Surveillance branch, but there are 4 branches within the Division of Cancer. We don't have any assignees from Comp Cancer or the Program Services branch, but those folks are all in Atlanta. And then I think most folks are aware of the Healthy Tribes program, which funds the good health and wellness in Indian country, tribal practices, and there's another one I can't remember the name of. But we also have 2 folks from Oops, sorry. Can you see that? I'm trying to fix this so I can. Yeah, TB from immunization branch. And we have, I think we actually do have one PHAP person who should be starting fairly soon. I recall getting an email about a Zoom meeting so that we could meet her, but I didn't include her name on this org chart. I will for the next time. And then next, just a brief outline of some of the things that I'll be talking about. Go over some background, some information about the Indian Health Service, the United States Cancer Statistics, or USCS, some of the methods that we're using to improve the estimation of cancer burden among AIAN POPs, including the IHS linkage, are restricting to IHS PRISTA counties, restriction to non-Hispanic populations, and then briefly go over some cancer data sources and the USCS data visualization tool. So first of all, for the background, we know that racial misclassification of American Indian Alaska Natives occurs in cancer surveillance and vital statistics databases. And we also know it varies by state. And that by decreasing misclassification, we can improve the accuracy of health indicators and program planning and resource allocation. Just for folks that aren't aware of the Indian Health Service, the IHS provides comprehensive health service, is the comprehensive health service delivery system for about 2.2 million of the nation's estimated 3.7 million AIAN. And it contains members of 567 federally recognized tribes and their descendants are eligible for services by IHS. It's the principal federal health care provider and health advocate for AIAN people. And I also put the mission, goal, and the foundation of IHS on the slide in case you wanted to look at it. But basically, IHS is the largest data set of AIAN in the US that is readily available. And that's why we are going to be using their data. So IHS is structured into 12 area offices, and I have a little map showing the 12 offices. There's Alaska, Albuquerque, Bemidji, Billings, California, Great Plains, Nashville, Navajo, Oklahoma, Phoenix, Portland, and the Tucson area. And then next, these are the IHS Purchase Referred Care Delivery Areas. They're formerly known as Contract Health Services, or I think all our previous publications all talk about CHSDA, which is the Purchase Referred Care Delivery Area. And these are the geographic areas within which purchase referred care are made available to IHS, supposed to be made available by IHS for anybody identified from the community that resides there. And this is a map that shows you the PRISTA counties in the US. So you'll notice that most of them are in the Southwest or in the western part of the US than in the eastern side. And just a little background on cancer registries. The purpose of cancer registries is to collect data on cancer occurrences. So they collect data on patient demographics, tumor characteristics, stage of disease, treatment, and outcomes. And in the US, there are two different programs. One is the NCI SEER program, which began in 1973. They collect incidence and surveillance data. They're population-based, and they have 11 SEER registries and 9 dual-funded registries that cover 34.6% of the US population. The other program, which is the program for the branch that I come from, is the CDC's National Program for Cancer Registries. It began in 1992. They collect incidence data, and they support central cancer registries in 46 states, the District of Columbia, Puerto Rico, the US Pacific Island jurisdictions, and the US Virgin Islands. And it covers 97% of the US population. So in order to create the US cancer statistics data set, we use data from both registries, the MPCR program and the SEER program. And this map shows you where the registries are funded from. So the states that are in blue are the registries that are funded by NCI or CDC's NPCR program. The states that are in green are NCI's SEER program. And the states that are like in a light minty color are funded by both CDC and NCI. But when you combine data from both programs, we can get 100% coverage of the US population. And next, I'll talk about some of the methods that we use to improve the estimation of cancer burden among AIAN. So the first method that we use is to link with the IHS administrative records. And we do these linkages with the central cancer registries for both CDC's NPCR program and the SEER program. And our goal is to identify AIN cases who are misclassified as non-native. The results are captured in the IHS link field, which is part of the NACER data layout. And it's item number 182 in the NPCR and SEER annual data submissions. And what we do with the data submissions is we create a race recode using race 1, race 2, and IHS link. So if you look at any data set that is part of USCS or SEER, they all incorporate the IHS link in their race recode. So if they have race AIN, you can be assured that the IHS link was taken into account for both of those data sets or databases. This is our linkage schedule for the cancer registries. For the states that are in green, we link those registries every year. For the ones that are in yellow, we link them every 5 years. And this is because the states that are in green have at least one PRISDA county in their state. The states that are in yellow don't have any PRISDA counties. This slide shows you the number of AIAN individuals identified by the IHS linkage for the 2006 data submission. And this is because this is data from the very first time that we did our linkage. Because since then, some registries have recoded race, so it's hard for us to measure the impact of the IHS linkage. But the blue bar indicates the number of individuals who were identified as AIAN by the cancer registry. And the gray bar with the number above it is the number of individuals that were identified as non-AIAN, but they link to IHS. So they're misclassified. So for Alaska, we have 70 individuals that were not identified as AIAN by the registry, but did link to IHS. And because SEER funds the Alaska Native Tumor Registry, we're pretty sure that those 70 individuals are American Indians. So folks that moved to Alaska and were diagnosed with cancer. In the Southwest, the misclassified individuals are pretty small, 423 individuals. And we believe that's because NCI funds the New Mexico Tumor Registry to collect AIN data for both New Mexico and Arizona. So they do their own internal IHS link prior to doing our national IHS link. So they're most likely capturing race for people that might be misclassified before even doing the IHS linkage that we do with the central cancer registries. And for the Southern Plains, there were 3,310 folks that were not identified as AIN by the registry, but did link to IHS. And this slide shows you what happens to the cancer incidence rates when you incorporate the folks that were misclassified. So the bars that are in gray are the pre-link cancer incidence rates by IHS region. The ones that are in green incorporate the people that were not identified as AIN on the by the cancer registry, but did link to IHS. So the biggest differences that you could see are Northern Plains, Southern Plains, and Pacific Coast, actually for all the regions. But in terms of comparing it to the US non-Hispanic white rate, which is the red dashed line, prior to the IHS linkage, Northern Plains and Southern Plains had cancer incidence rates that were lower than the US non-Hispanic white rate. But once we incorporated the folks that were not identified as AIN by the cancer registry, but did link to IHS, the incidence rates were actually higher than the US non-Hispanic white rate. Post-linkage. So the second method that we do is we restrict our data to the IHS purchase referred care delivery area counties. And this map just shows you the 6 IHS regions that we created and aggregate our data by. And then the further restriction we do is to restrict to only the counties that are in blue. We did look at racial misclassification by county a couple of years ago, and we examined 3 data sources. So 2 of those data sources involve linkages with IHS. So as you would expect, we did find that sensitivity was better. So in CHSDA counties, the records were more likely to be correctly classified than in non-CHSDA counties. And there was better agreement between data sources in CHSDA counties and non-CHSDA counties. So to make sure that we weren't being falsely, or we decided to use a third data source, which was independent, did not use IHS at all. And that was the National Longitudinal Mortality Study. And we found the same thing, that race was better coded in CHSDA counties than non-CHSDA counties. So this is the reason why we restrict our data to IHS PRISDA counties. The third method that we do is we restrict our data to the non-Hispanic population. And that's because when we were working on our mortality data set, we noticed that there were some individuals in certain counties. There were more people dying in counties than we had living there. And that led us to contacting census and trying to figure out what was going on. And basically, what they were doing in census was modifying race. There was differences between 2000 and 2010. The 2010 algorithm only, there was a problem with people who were identifying themselves on census as Hispanic and not choosing a race. For in 2000, what they did with those individuals is they distributed those folks into just the white, Black, and I think other race categories. In 2010, they distributed those folks into all the race categories. And what that ended up doing was increasing the Hispanic AIN population by 115%. So I just put a little graph here that shows you that if your incidence number remains the same, but your population changes, the incidence rate decreases. So because of that, we decided to restrict our data to the non-Hispanic population only. And I have some slides that kind of show you what happened. So this shows you all cancer sites combined for the US. Data is restricted by PRISDA counties by IHS region. The light green bar shows you the white rate, which includes Hispanic persons. The green bar shows you the non-Hispanic white rate. The light blue bar indicates AIN regardless of Hispanic origin. The dark blue bar shows you the non-Hispanic AIN rate. And then above the little bars, I just showed you the number of cases that we excluded when we restricted our data to non-Hispanic. So for the Northern Plains, we took out 80 cases, and that increased our incidence rates because of the population that we also excluded. And you could see the biggest impact was for the Pacific Coast. And I believe that was mostly from California. So when we took out 537 cases, it took out a large chunk of the Hispanic AIN population. And there was a huge difference in the incidence rates before we did that and after we did that. Next, I'm going to talk about the USCS AIN Cancer Incidence Database. This is a data set that we created that incorporates the IHS linkage variable. We aggregate the data by IHS region. So these are the 6 regions that we aggregate our data by. And we have data from 1999 to 2017. And we have various USCS AIN data briefs that are available. I put a link down below on where you can find them. I think our most recent one was on lung cancer. And we have another one coming out in November that's going to be looking at the urban AIN population. So that's something we worked on with the Urban Indian Health Institute. And then next we have some cancer data sources. So I put together a little table that has information about the USCS AIN database, the USCS restricted access data set, the USCS public use data set, and just one broad category for this year data. And just broke it down by what states and territories are included, what geographic level is available, and the different ways you can access the data sets. And then web address and contact information, the age groups, the diagnosis years that are available, and all the various sources have race for all races combined, white, black, Asian Pacific Islander, and American and Alaska Native. And they do have Hispanic origin in all those data sets. The other thing I wanted to talk about is our USCS data visualization site. I know we've had a couple people that have had questions because they've used the USCS DataViz website to look up AIN data, and the incidence rates are a lot lower than what they were expecting. So I just kind of wanted to point out that we have AIN data in like 2 different parts. So the USCS DataViz has data available by state. So you can select each state to look at the incidence rates. It includes the IHS linkage, but it does not restrict to PRISDA counties, and they do not restrict to non-Hispanic AIN. And the other thing is that the states have the option to suppress their data or not. So there is AIN data missing for Delaware, DC, Illinois, Kansas, Kentucky, New Hampshire, New Jersey, New York, Vermont, and West Virginia. And that was just because the state chose that. Now, the other thing that we have in USCS is the USCS DataViz AIN Incidence Analytic Database module. Now, this data pulls from the database that I create and that we publish on. It includes the IHS linkage. It restricts to PRISDA counties and restricts to non-Hispanic AIN. But you have to go to a special place to find it, and I'll talk about where to find that later. And the other thing it does is we aggregate the data by the 6 IHS regions, which is why some of the states that choose to suppress their AIN data were okay with including it in the AIAD module, because their data was going to be aggregated at the region level. So it has 100% coverage for the US for AIN. And this is some information on how to get to that site. Not quite easy to find. But if you go to the USCS homepage, which is the link that I have at the top of the screen, you have to go to the More Topics tab. And then once you go there, you have to choose your data set. And you have to select AIN restricted to PRISDA only. That'll pull up the USCS AIAD module. And once you do that, you'll see that the map will show you the 6 IHS regions. And this is the really long link that you can use to get there. But this is the home screen. So it's good. It's going to show you the AIN non-Hispanic rates for new cancers by leading cancer sites for the whole US, and then also for non-Hispanic white. And at the bottom of the screen, it'll show you the rates of new cancers by IHS region and gender. So there's little drop-down boxes where you can try to, you know, if you're interested in lung cancer, you can select lung cancer. If you're interested in looking at the East region, you can select East region under IHS region, and then you can select by gender. And so a little bit more helpful hints. So for the USCS AI-AD module, you'll see a couple little links on top. There's a Facebook, Twitter, and it looks like 2 chains. If you click on that link, it actually copies the long link for you. Let's say you were looking at breast cancer in the Northern Plains and you wanted to show it to a colleague. All you would have to do is click on the link button, which will copy it, and you can paste it in an email and send it. And when somebody clicks on that long link, it'll take them directly to the page you were looking at. Other helpful things about the USCS DataViz AI-AD module is the ability to export data. So you can export data in a table, or you can export the charts. You just have to click the little export button and it'll pull up what you were trying to export so that you could paste it into a PowerPoint slide, which is what these two are. And then to choose the IHS region, you can use the drop-down button under Choose IHS Region, or just click on the region in the map. And that will give you the data for that region. The bottom of the slide just shows you whatever cancer type you have selected by the IHS regions. So if you didn't select anything, it would show you all cancer sites combined. If you selected lung, then it would show you lung cancer incidence for various regions for AIN and non-Hispanic white. And there's a whole bunch of footnotes if you're all interested in seeing anything specific about the data set, including a link on where we've been getting the counties. The next thing I'm going to talk about is our mortality data. I call it the IHS NDI linkage saga, because this is something that we started when I first started with the cancer registries. We figured that since those linkages went off without any issues, that the linking to NDI would be the same thing. Turns out we were wrong. But our initial goal was to link the administrative records from IHS with the National Death Index and identify AIN deaths misclassified as non-AIN, and use this improved data for various reports and papers. And it turned out to be a lot harder than we thought. First of all, the National Death Index is very expensive to link to. So what we ended up starting to do was doing state-by-state linkages. We tried to link with every state in the US and ran into a bunch of different problems. We were able to complete quite a bit to give us some information. For instance, like for Oklahoma, you'll see that before we did the link, these were the number of AIN decedents on the death certificates. And after we did the link, we identified like 10,000 people in Oklahoma who were not identified as AIN, but did link to IHS. And then after we did that initial project, Elizabeth Arias and folks from her branch published this report that looked at comparing death certificate race to census race. And what they found is that 55% of people who identified themselves as AIN were not coded as AIN on their death certificate. So these are people that were coded as another race. And using the pilot data that we did with the state-by-state linkages and the NLMS data that shows the misclassification of AIN, we were able to get the money that we needed to link the 1990 to 2009 death years. And when we did that, we created something called, we got a file that has the IHS field amended to the National Vital Statistics System data. And when we created a race recode using people that were coded as AIN on the death certificate. And then we also included folks that were not AIN on the death certificate, but did link to IHS. And we came out with a publication for AJPH that I'm going to be showing you a couple things that we learned from it. So this shows you at the time, the Chisda counties that we restricted our data to in the same IHS regions. This is some pre and post numbers of the individuals that were misclassified. So the blue bar are the people that were identified as AIN on the death certificate. And the green bar is the number of individuals that were not identified as AIN on the death certificate, but did link to IHS. And this is what happened to the mortality rates after we included the folks that were misidentified. So the blue bar shows you the mortality rates based on race using from the death certificate. The green bar shows you the mortality rates once we incorporated the folks that were not identified as AIN on the death certificate, but did link to IHS. So it was a huge difference, and mortality for all causes was all greater than the US non-Hispanic white rate. We were able to get some life tables so we could look at life expectancy. For the non-Hispanic AIN population, life expectancy for females was 74 years old. For non-Hispanic white females, it was 80. For males, AIN was 68. For white males, it was 76. So we knew there was big differences between life expectancy. And then this is, I'm gonna show you a bunch of color-coded charts. This just shows you some of the data for the US. So this is the causes of death, the AIN ranking, and then parentheses, the white ranking, the AIN rate, in parentheses, the white rate, and then the rate ratio. So the differences between the AIN rate and the white rate. And the asterisk indicates if they're statistically significantly different. So I'll just give you a chance to look at the different causes. I have them color-coded. So if there's a particular cause, you can just note the color. And on this graph, it shows you the leading causes of death. Move all these pictures, sorry. For the 6 regions. And you can see there was differences for like heart disease. It was the #1 cause of death for Northern Plains, Southern Plains, Pacific Coast, and East, but was the 3rd leading cause of death for Alaska, and the 2nd leading cause of death for the Southwest. And then the different rate ratios. We also were able to look at trends data. So the green bar shows you the AIN male trend compared to the non-Hispanic white male trend, which is in red. There is basically, has been no difference between 1990 to 2009 for AIN males, but for non-Hispanic white males, their rates have been decreasing over the years. This is a graph that shows you the US leading causes for females. And I have the same information that was in the previous one, which is the AIN ranking, the white ranking in parentheses, AIN rates, white rates in parentheses, and the rate ratios. And again, this one's color coded also. I tried to keep the colors the same, but some of the causes are slightly different, so they might not be exactly the same. And then these are the leading causes by the IHS regions for females. So here, cancer was the leading cause of death for women in the Northern Plains, Alaska, Southwest, and Pacific Coast, but it was the second leading cause of death for the Southern Plains and the East region. And then trends. So for AIAN females, what we found is that the mortality rates have been decreasing or increasing for all causes from 1990 to 2009. And while the non-Hispanic white female rates have been decreasing. So what we're trying to do now is update our data. We're hoping to link to catch up our linkage from 2010 to 2019. IHS, of course, has a special interest in the 2020 deaths because they want to look at COVID deaths. So trying to see if there was misclassification in COVID deaths. And our AIAN mortality database is going to be available to the CDC, DCPC, IHS, OPHS, and tribal epicenters. And then next, I wanted to show you this little slide about some of the projects that I've been working on with Rodney and the Seneca Scientific Solutions Plus. So what we were trying to do is utilize the national data sets, our incidence and mortality data, to provide an accurate picture of health disparities for all enrolled and non-enrolled members of the Haudenosaunee, and provide this data for modifying interventions in health systems. So what we've done is restrict our analyses to counties that comprise the following territories: Allegheny, Cattaraugus, Oil Springs, Oneida, Onondaga, St. Regis, Tonawanda, and Tuscarora territories. And on this little map I showed on the right is what we call the IHS East region. And I kind of blew out the New York State just to show you which counties that we've been including in our analysis. One of our previous publication was looking at mortality data from 1990 to 2009. And I think next we want to publish something looking at cancer incidence data. So the AI80. And the last thing I wanted to talk about is tribal linkages. So I've been helping out the Intertribal Council of Michigan. What they were trying to do is link tribal enrollment data with the Michigan Cancer Surveillance System to produce tribal cancer summaries. And we originally were trying to build up the capacity of ITCMI to pursue tribal linkages, but with the turnover, it's been hard to have a linkage person in their organization. So I basically have been going out and helping them whenever they're ready to do tribal linkages. We've done, let's see, three different tribes. The first time was one of their larger tribes, and then we did 2 more. And then I went back again and we expanded the linkages for one of their tribes. Instead of just cancer data, we also linked birth data and death certificate data. And we were hoping this past spring to update all the linkages again, but we haven't, obviously because of COVID, haven't been able to do that. So I'm not sure when we're going to be updating those linkages. But this is what I really wanted to show you. So this is the data, or this is a little Venn diagram that shows you the number of AIAN that were reported by the state cancer registry, and then also the number of individuals that ended up linking to IHS, a number of individuals that ended up linking to one tribe in Michigan. So the Michigan Cancer Registry identified 569 individuals as AIAN. And then I came in and I did the IHS linkage, and we found an additional 565 people who were not identified as AIAN by the registry. but those cases did link to IHS. And then we came in with tribal enrollment for one tribe. We did that link, and we found an additional 168 individuals that were not identified as AIN by the registry, by IHS, and basically were misclassified also. So we know that the IHS linkage isn't perfect. It is the best thing that we have right now. IHS only covers about 35 or 53% of the AIN population, and tribal linkages might be able to help increase that. But any questions?
Thank you, Melissa. We have one question right now on deck. The question is, why are some states not participating in the state linkages? Lack of awareness.
The state linkages? So for the cancer registries, everybody does participate in the IHS linkage. They just opt to not have their data displayed on the USDS DataViz site. And then when we tried to do the state-by-state vital statistic linkages, that was a lot harder because we were trying to work with everybody. Since then, we've abandoned the state-by-state linkages and went straight to linking with the National Death Index, because that data source has all deaths in the US, and it was like a one-stop shop. But it's really expensive. So we are able to do a linkage with all the deaths in the US now.
All right, so for participants who came in late or didn't see the message in the chat box, if you have any questions now for Melissa, feel free to type those into the chat box. And I know this maybe is outside the scope of the actual work that you're doing, but I did notice that there were, cancer-related deaths in women were much higher, correct? Across the country. And I also noticed that unintentional injuries or unintentional deaths were much higher in men. Has there been any studies or indication that could explain those differences?
No, actually, it's kind of a pattern that we first noticed when we did that project. I'm not sure. So what we've been doing is just trying to make sure that the cancer and mortality data get out there so that folks could actually look at that type of, try to see why that's happening. Because I know one of the things we noticed was that lung cancer seems to be increasing. Mm-hmm. It's decreasing and it's lower. So it's been interesting to look at the various causes of death and the cancer incidences by gender.
Our next question is, how can clinics support this work and reduce misclassification? How can community nonprofits and other organizations work to reduce misclassification?
Well, I know there is misclassification in most everything because people just don't really ask about race. So for death certificates, the person filling out the death certificate just basically will look, and I didn't spend too much time on the National Longitudinal Mortality Study, but there was a difference in gender. More AIN women were misclassified or were coded as white on the death certificate than men. So it's just, and then when you go to your doctor's appointment, just think of how often people ask you your race. They probably don't. And that's something I know the New Mexico Tumor Registry was thinking of doing, is inserting a paper that they were requiring for everybody to make sure they fill out their race and stuff that gets coded incorrectly, just so that they can compare it to people that don't fill out that information.
Do you have any recommendations to improve data entry?
No, other than, asking people.
And I think that goes to what you just said. It actually is we have to first identify them. And I know at Roswell Park up until a few years ago, I don't know exactly how long ago, but Native American was not an option on the intake sheets or the admission forms. So that had to be added after.
Yeah.
And I think that happens often. Another question we have here is, when will the COVID data come out? Next fall, or will you have data sooner to evaluate if cancer rates increased?
So that's something that we're just about ready to send our file to NDI. And that's the thing that we're trying to figure out now is timing, because we know that the 2020 early release file is going to be ready in January. So for us, we're trying to figure out, should we send our file to NDI now, or should we wait till January so that we can make sure we grab the initial COVID deaths? The final files aren't available for NDI until October or November of next year. But I'm pretty sure that most of the COVID deaths will be captured in the early release file. So that's something we need to talk with IHS about, on what their preference we want to go for. Wait a little bit longer to make sure that we can grab the early release 2020 cases or deaths, or send a file now and then try to catch them later.
Is the COVID-19 data going to be linked to comorbid illnesses?
I know the registries are going to be collecting COVID data. Mm-hmm. It's, I don't know. We tried to see if that we could use our cancer registry linkage as a way to link some COVID deaths, but IHS was talking with their legal department and it turned into a big old thing, and it turned out we could do that. Because I was like, fingers crossed, maybe we can make this happen, to at least get an idea of what misclassification is in the COVID case data. But that didn't work out. But the cancer registries are going to be tasked with collecting COVID information. Of course, the registries are 2 years behind. So this fall, they'll be submitting 2018 data. So we won't see 2020 data for 2 more years.
And for those who are joining us and see that Melissa and I shared a laugh, it's because I think when you work in the, I think with this type of work in the Indigenous community, there's many pitfalls and challenges and hoops and red tape that occurs that makes normally simple projects or straightforward projects very, very challenging. So I think we can kind of relate to that pain of trying to obtain data or make these linkages and running into a lot of obstacles. What do you think some of the implications are, health implications of misclassification?
The health implications?
Yeah, and actually, why don't we just skip my question, because we have another good question coming in here.
Okay.
Is the COVID-19 data going to be linked to, oh, okay, that was actually the first question. Okay, this work is extremely important to ensure racial and gender equity. What are some things you might say to healthcare staff and other public health employees about the importance of appropriately classifying AI/AN relatives?
I mean, I think COVID is a good example. We know that a lot of our communities were impacted by COVID. So just talking about how it's hard for us to figure out, what needs to be done when in our tribal communities if our data isn't getting classified correctly. So it's important to know what race and ethnicity people are, and especially in these national data sets, because if our data isn't accurate, then we're not going to be able to figure out what's actually going on in our communities.
And I think that speaks to my previous questions about some of the overarching consequences of misclassification, how this could affect our communities. And certainly, speaking from our community down here in Western New York, Southern Western New York, there was several, it's not several, there was a few cases of COVID-19, a few mortality cases. They've been relatively few and far between. We've seen some sporadic outbreaks, but of those people who were affected the most were Native American people living in our communities. And I didn't really see much press on that or much emphasis. So I think that, to your point, classifying people appropriately can bring appropriate attention to these issues. So we're aware and we're all together as a community. Oftentimes our communities are connected, but still unique and different. Within the city of Salamanca, for example, where I live, there is multiple distinct communities within the city itself. So I think that in a way brings us together and helps empathize with our communities and some of the challenges that they're facing. And we're doing pretty well on time, Melissa. I think that was the last of our questions. Do you have anything else that you want to add or talk about any future projects that you have in the cooker right now?
No, I realized that I had hidden my Navajo cancer slide, but one of the other things that we've been doing is looking at cancer among the Navajo. We are working on our third report now. So let's see if I can unhide this guy.
Yeah, we can know.
Yeah, so we're working on our third update. So we've published previous versions. I can't off the top of my head remember. I think we did 1999, 2004, and then we did 2005 to 2013. And the one we're working on now is 2014 to 2018. So we use data from the Arizona Cancer Registry, the New Mexico Tumor Registry, our USCS AI-80 data, and US mortality data. But I think for this particular version, we're hoping to use the IHS link mortality data, so our USCS AMD file. And this is something that's been pretty helpful for Navajo Nation. And I think that on top of what we've been able to do with the Haudenosaunee are good ways that, ways that we've been exploring using our national data to help tribes that don't fall within our region, our IHS region data. Oh, and the other thing I kind of wanted to mention is that, so for a long time, data was only available, every time you look for data, you only had data from the SEER registries. And because of that, the way the SEER registries were created is they capture data from certain segments of the population. So for the AIAN population, they were collecting data from New Mexico and from Alaska. And they funded this special data set called the Arizona Indians. So that is where New Mexico is collecting AIAN cases from New Mexico and Arizona. And from the other slides where I showed the incidence rates, you could see, the problem with that is when they were doing this, they were actually collecting data from one of the regions that had the lowest cancer incidence rates, the highest. And what that ended up doing is falsely showing that AIAN cancer incidence was low. So I think by using the MPCR data, we're able to capture what's going on in the northern plains, the southern plains, instead of just what's going on in Alaska and New Mexico and Arizona.
And I would think that, if there's numbers that are vastly underreported, then I think there could be maybe a false sense of security and that these issues don't really exist. And by doing this type of work that you're doing, it helps all of us, including us at the Roswell Park Center for Indigenous Cancer Research. I'm sure all your colleagues out west, a snapshot of what is really going on there. And I really find it fascinating that your work really kind of looks between numbers. I think in research, you often have to read between the lines sometimes to actually get a big picture, get a better idea of what's happening in a particular initiative or a particular research project. And sometimes that can be a little bit misleading. So I know that for our team, this data that you're producing allows us to make better recommendations or cater some of the research or community outreach and education to the community based on varying degrees of need based on these numbers and cancer, specifically as it relates to cancer education and research. So I think without your work, we'd be in a very hard place right now in terms of gaining some traction and figuring out what direction we should be heading in terms of helping our communities. So we wanted to thank you for all your work and your continued work working with myself. And I just wanted to make one comment here. One of our attendees had just said that this work is this is important, sacred work that supports the wellness of relatives and future generations, and to thank you. And I think she echoes the feelings that we all have today. So if there's no further questions from our attendees, and Melissa, if you have nothing else to add, I think that we can conclude this really telling webinar today, and we'd love to have you on again in the future. So Nyawe.
Sure. And then I guess the one thing I will mention is I do realize that having data aggregate at the region level may not be helpful. So in our talks with IHS, there has been interest in us aggregating our data at the IHS area level. So the 12 areas as opposed to the 6. So that's something that we are going to start pursuing. I think with the mortality data is when we're going to start playing with it. And once we figure out how to do it with the mortality data, we'll apply it to the incidence data. But one of the things that we are hoping to eventually get out the door is to create something that we've been kind of thinking or calling the IHS cancer area profiles. So a source that would have cancer incidence data by 12 IHS areas, and then also pulling data from GIPRA, IHS GIPRA, and BRFIC data by the IHS area level, just so that it's a one-stop shop. And we have talked to the other branches in our division about putting in screening recommendations and just trying to get all the information that everybody might need in one place, instead of having to go to, this website, that website.
Yes,
So
yes, I know that struggle.
We're aiming for.
Well, great. Well, we really appreciate your future work and efforts in this topic, and also honoring the individual communities themselves who know that data collection, data sovereignty is a very polarizing topic in our communities. So be able to do this work in a very responsible, respectful way is much appreciated. So thank you, Melissa, and we will see you again. And thank you
Okay.
for tuning in.
Alrighty.